Yeah, well, the first UltraPath I attended in Crete took me 56 hours to get there, and 11 flights. There was 5 flights there and 6 flights home. So that was quite grueling. I got there a day late and I had to leave a day early, so it was a quick visit. Yeah, so today's presentation is a condition that I had not encountered before, so it was a learning exercise for me, and hopefully you get something out of it. But firstly, I'd like to thank the organisers for the tour of the harbour last night. And I'd also like to thank Sibel for the tour of the convention centre. I thought we were going to get arrested at one point. And a shout out to everyone online. I've noticed there's some Australian and New Zealand participants who've been on all afternoon, all morning. It's currently 5 o'clock in the morning, Thursday morning there, so shout out to them. And when I found out I was in the ciliopathy section, I thought I'd Google AI and ask, is there a relationship between ciliopathies and this condition? And it said, well, yes, there is. Well, some ciliopathies can cause renal disease, and the tubular injury can be similar in those conditions and this condition. So that's a tenuous link. But anyway, this is my team back in Adelaide. Dan up here was in Sydney at previous UltraPath, and so is Max, and there's Elvis and Renata. We don't have much contact with the pathologists. They're a mile away in another building, but we do the best we can. Doesn't want to advance.
Sorry. There you go.
Thanks. So this is a little bit of information about the case. A female, 27. She had proteinuria detected during pregnancy. However, it didn't resolve after the delivery of the baby. Her serum creatinine was persistently raised. She was not diabetic. She had normal blood pressure. She had normal complement levels, and all serological tests were negative. So she had a renal biopsy, and I'll just summarise the light microscopy findings. There was 50% glomerular obsolescence, and the intact glomeruli were unremarkable. There was minimal interstitial fibrosis and minimal interstitial inflammation. The pathologist noted that occasional tubular cells showed nuclear enlargement, and he wondered, could that be regenerative change or viral infection? But he wasn't really sure. But that was the summary of the light microscopy. And I don't know about you, but every Wednesday we have a renal meeting, and it's at 11 a.m. And if we've got 3 or 4 renal biopsies to look at and get them ready for the meeting, we have to find glomeruli, cut sections, stain them, work out what we're actually looking at, and take photos and process them and get them into the computer system. So I looked at this with 30 minutes before the renal meeting, so I really didn't have a great deal of time. It's all a bit of a rush on Wednesday mornings. Plus, you've got to leave yourself 1 minute to go to the loo for the meeting. So you're a bit stretched on the Wednesday mornings. So the EM, it showed no deposit. There were some thin membranes, and there was reasonable amount of foot process effacement. There is effacement along quite a few of these glomerular basement membranes, but there are areas where the foot processes are intact. There's certainly some bleeding. I thought, well, maybe it does account for the proteinuria, but I thought another picture here, a beautiful example of blebbing of the podocyte. Talking about Homer Simpson earlier, some of these, that looks a bit like, I mean, Bart Simpson, that looks a bit like Homer to me. Some of the membranes are thin. There's variable foot process replacement, but there really wasn't much to go on. No immune complexes, no tubulo-reticular inclusions, nothing terribly outstanding apart from the podocyte injury. So following the renal meeting, the doctor had mentioned that there were these large tubular cell nuclei. I thought I'd go back because he did wonder if there was a viral infection. So I went back to have a look, see if I could find any of those cells and look for viruses. I certainly found the cells, but I didn't see any viruses. And this is what they look like. Just to orientate you, up here is the tubular basement membrane, and here we've got a row of epithelial cells. Some of them were had these endocytic vesicles, but some of them had these very large irregular nuclei, and they were scattered about. Some of them showed quite convoluted nuclear margins, and some of them showed clefts and very irregular, very large. Now, there we are. Some of them showed nuclear bodies. There's one there and one there, which could be misinterpreted as some sort of viral thing, but no viruses were detected, but certainly irregular nuclei. And I thought this area was interesting. You have the glomerulus on the right here, and some of the major vessels, either afferent or efferent, and over here you've got your distal tubules. So we're near the juxtaglomerular region of the glomerulus and associated tissue. And if you note these three cells up here, they're all very irregular. So it's interesting that at this part of the system, we get this cluster of atypical cells. I don't know if this is significant or not. Also, a lymphocyte here, just having a look at what's going on. So I certainly found the cells, but no viruses. And the immuno was fairly unimpressive. There was only 1+C3 in the capillary loops, and no other positive staining. All the others were negative. Stains for BK and adenovirus were negative. So at this point, the pathologist, we came to some sort of a diagnosis that was a bit open-ended. Here we go. So the final diagnosis at that point was 50% glomerular obsolescence, tubular nuclear pleomorphism, possibly regenerative, but exact nature not elucidated. Viral cytopathy was considered, but not proven. The IF shows 1+C3 only. EM shows no deposits and a degree of podocyte injury. So the cause for renal impairment was not identified. And that was that, sort of unsatisfactory conclusion to that. But as happens, you have to deal with the next specimens, and sort of that was that. But if you fast forward 2 months or so, we were notified by the patient's treating nephrologist, and she did more extensive investigation into the patient and the patient's family history, and ordered some genetic testing. And it came back from that the patient was found to have a FAN1 gene mutation. So the pathologist issued a revised diagnosis of FAN1 related Karyomegalic tubulointerstitial nephropathy, or also called Karyomegalic interstitial nephritis. I've used the first term for this presentation because there was no tubulointerstitial inflammation. I don't know why, but I have a citation at the end of this presentation. They've used the former terminology, so I've stuck with that. So I was kicking myself at this stage. I had seen pictures of this in Colvin and Chang, and it didn't click. And I even had a paper about it on the computer. So I was a bit dirty on myself for not thinking of it, but it's been a good learning exercise for me. So what is FAN1 related kin? It's a rare, slowly progressive kidney disease. Patients have proteinuria, which is often asymptomatic. Renal impairment begins at 20 to 30 years of age and usually leads to renal failure at 40 to 50 years of age. And the histological hallmark of this disease is an enlarged dysplastic nuclei, or karyomegaly, in kidney tubular epithelial cells. This karyomegaly may be observed in other organs such as brain, prostate, lung, and liver. And the patients may have pulmonary complications, elevated liver function tests, which are also often asymptomatic, and cancer. So kin, the morphology was first described in 1974 in a young lady with hepatocarcinoma. And Michael Mihach gave this name, kin, in 1979. And I looked him up. He was actually at UltraPath in Germany in 2012. And he's was a prominent renal pathologist. So taking a step back from the FAN1 related kin, a little bit about the karyomegalic process. The main cause is the FAN1 gene mutation, which was identified by Job in 2012, and it follows autosomal recessive inheritance. But there are other causes and associations with this disease, such as chemotherapeutic agents, some platinum-containing chemicals, cisplatin, carboplatin. I don't know if fosfamide. I don't know that. I'm sure some of the clinicians here do. Also, environmental toxins can bring about this disease. Ochratoxin A is a natural mycotoxin. In other words, it's a mold contaminant of cereals, coffee, dried fruit, wine, and spices. So a lot of these environmental cases have been reported in Northern Africa, Morocco, and Tunisia. And apparently, by the citation paper I've got, rarely some infections can cause this disease as well. So what does FAN1 mean? Well, it stands for Fanconi anemia-associated nuclease 1. This enzyme maintains DNA integrity by repairing interstrand crosslinks within the DNA molecule. And some factors thought to be involved in the pathogenesis of this disease. The defective DNA repair in the tubular cells, or some of the factors here, defective DNA repair in tubular cells, mitochondrial dysfunction, and elevated oxidative stress in total lead to tubular injury, ischemic injury, and glomerular obsolescence. And this is the reference I was talking about. It's only come out fairly recently this year by Klintz et al. Genotype, phenotype, characteristics, and disease progression of FAN1-related karyomegalic tubulointerstitial nephropathy. So this was an international survey of kin FAN1 involving 86 families from 22 countries. And from within that cohort, they identified 122 individuals with kin FAN1. So, closing comment, and this is more a question to you and than a comment. When large pleomorphic tubular cell nuclei are identified in a renal biopsy, now that I'm more aware of this, I consider regenerative change, viral infection, and karyomegalic tubular interstitial nephropathy, which may be caused by the FAN1 gene mutation. I guess my question to everyone is, what other conditions can lead to large pleomorphic tubular cell nuclei? That would be, if there are other things to consider other than those three. So thank you for your attention.